Thank you all for joining. I'm talking today about gastric tubes in neonates, and I'm sure many of you are active clinicians in the neonatal intensive care unit and work with gastric tubes every day, many times a day. In spite of the commonplace use of gastric tubes, there's a lot of our practices that lack evidence or have more evidence in the adult and pediatric population, leaving us with controversies and unanswered questions. So hopefully today we can go through and discuss some of those and kind of look at what the evidence is that supports best practice. So we'll look at indications for gastrointestinal tube use in the neonate very briefly, and then move on to standards of care and controversies related to the use and management of gastric tubes. And finally, talk about complications of the tubes and how they can be avoided. So most of our gastric tubes are placed in the NICU either for drainage or for feeding, and we'll focus mostly on the feeding today. As far as selection of sizes, there are various sizes available. Mostly in the NICU, we're using a 5 French, 6 French, or 8 French. And I've noticed over the years that it seems like we're gravitating more towards the smaller sizes, the 5 or 6 French. Again, there's not a lot of evidence that supports the use of a certain size, although folks tend to use a smaller size if it's passed nasally, and a smaller size in a smaller infant. There are some recommendations that nothing over a 5 or 6 French is used in infants under 1,500 grams, and others recommend 1,000 grams. So there is some variation in practice, but most importantly, if it's used for drainage, the smaller tubes don't drain very well, and the larger tubes seem to be better tolerated if placed orally. And we'll talk about that controversy in a little bit. So as far as materials used for gastric tubes, traditionally and historically, PVC has been a common material. That's the cheapest material to make feeding tubes out of. The only thing is that it's very stiff if it's not mixed with a plasticizer. So in years past, a plasticizer called DEHP was used very commonly, and this was linked in animal models with cancer in adult populations or infertility in male infant populations. And so while there's no hard and fast evidence because of that link, the FDA issued a public health notification in July of 2012 recommending against the use of DEHP as a plasticizer. So there are still some companies that make PVC feeding tubes, but they use a different plasticizer in order to make it soft. Polyurethane is the more common material these days because of the abandoning the use of the DEHP plasticizer. It is a little more expensive, but is soft. And then finally silicone, which is very expensive. And usually the tubes that are made with silicone are the long-term feeding tubes so that they stay in place for a longer period of time. And then I want to talk a little bit about nutrient loss in tube feedings because if we're using this tube for feeding infants, we want to make sure that they're getting all of the nutrients that we intend to give them. But it turns out, as I'm sure many of you are aware, that we're losing fat primarily, although more than that I'll show in the next slide. The first study looking at fat loss was published in 1978 and showed a 24% fat loss. And in that study, they were able to recover some of that fat by washing the tube. So in other words, if you flush the tube when the feeding is finished with some water, that some of that fat then would be passed on to the infant. And then other studies that you see listed down later in the slide, Narayana in 1984 looked at the syringe position, and I think that's something that's very popular clinically, that people tend to angle the syringe either at a 30-degree angle or straight up in order to deliver the fat first. and certainly it works to deliver the fat first, but in some other studies, the angle of 30-degree position made no difference in fat loss. But when we look at other things that affect fat loss, like the tubing surface area, so the larger around the tubing is, the larger the diameter, or the longer the tubing is, the more fat loss occurs. And then as well, the amount of time the feed is exposed to tubing. So in this study by Rogers, published in 2010, they compared gravity feeding to a 30-minute feeding and in continuous feeds as well. So they found loss of calcium in addition to fat loss, and in continuous feedings, fat loss was as high as 50%. The losses were a bit lower when the feeding was mixed with human milk fortifier, so in other words, mother's breast milk or donor milk mixed with human milk fortifier, as compared to a powdered bovine-based fortifier. So significant loss in fat, again, based on time of exposure to the plastic. And then Taken in 2009 looked specifically at the loss of triglycerides and carotenoids, and they found a significant loss, although they theorized that may have been related to it adhering to the tubing and or to peroxidation, because they found that the losses were slightly higher when the feeding was exposed to phototherapy. But the carotenoids are important because those have been linked to a prevention of cancer and cardiovascular diseases in adults, and more recently has been shown as important in preventing chronic lung disease in neonates. So while we understand the fat is important for weight gain and nutrition, carotenoids are important in other ways as well. So the clinical significance of this data is that shorter tubing might be preferred, the shortest feeding time when it's medically possible, and angling of the feeding syringe doesn't seem to be significant. So the fat is delivered first, but you still have loss in the tubing. So just by angling the syringe really isn't going to prevent fat loss. So we'll talk just a little bit about insertion of gastric tubes and the controversy of nasogastric versus orogastric, measuring for insertion and confirmation of placement. So there have been various papers published looking at nasogastric versus orogastric with conflicting evidence. We know that there is some increased airway resistance by partially occluding a nair in an infant who is an obligate nose breather. Cook in 2002 found increased incidence of periodic breathing and central apnea, but two other papers published in 95 and 2010 showed no difference in apnea and bradycardia with nasal versus oral placement. And then there is some evidence that the tube doesn't come out as easy when it's passed nasally. It's easier to secure, and babies are less likely to push it out with their tongue and possibly decrease that activity of tongue thrusting that happens when the feeding tube is right there where it's automatic for them to thrust with their tongue. And the Cochrane review of all the available studies found that there was insufficient evidence to inform practice. So we really don't have good evidence about whether nasogastric or orogastric is better. So this is just a comparison of the pros and cons, if you will, of nasogastric versus orogastric. Nasogastric appears to be more comfortable with passage. You can see over on the orogastric side there's more gagging and potential for bradycardia when it's placed. Seems to be, at least for some babies, more of a vagal response. However, with nasogastric, you have more airway resistance, perhaps more periodic breathing and apnea, less risk for displacement, and over the long term, and especially with harder tubes, a potential for nasal erosion. And the orogastric tube, again, may lead to gagging during PO feeding, so sometimes we'll leave the tube in while we're trying to nipple feed the baby with the intention of gavage feeding whatever they don't finish, which makes it difficult for the baby to nipple as well. And larger tubes are better tolerated if placed orogastrically. So then just to move on to measuring for insertion, these are the methods that we'll talk about: the nose to ear to xiphoid method, nose to ear to mid-umbilical, nose to ear to umbilical, and then there are some papers that are promoting a length-based or weight-based formula to calculate the placement. But first, just to talk for a minute about the ideal placement of the tube, because we all understand that a tube is misplaced if it goes into the trachea and could potentially infuse feeding into the lungs. But in order to get the right measurement for placement, we want it in the center of the stomach, as this diagram shows, and not up into the esophagus or down past the pyloric sphincter, nor do we want it curled in the stomach. So that's the placement, the ideal placement that we're looking for. So this is a summary of several papers that have looked at the placement and what measurement actually gives you the best correctly placed tubes. And you can see, again, on that previous slide I had that the nose to ear to xiphoid is no longer recommended, because if you look at this first study, only 44% of those tubes were correctly placed. In this study, only 41%. This one down here was higher, but still not as high as the other method of nose to ear to mid-umbilical, which is the recommended measurement now. And this, just to help you with this abbreviation, this group created a minimal insertion length. And this is the paper that looked at a weight-based formula, got as high as 96% in accuracy. This is the length-based formula, as high as 78%, but the nose to ear to mid-umbilical was still more accurate in the neonatal population. And some of these studies include some pediatric patients as well. So once we measure for the best placement, next is to confirm that the tube actually ended up in the place where we desired it to be. So we want that to happen after initial tube insertion, before any intermittent feeding or medication administration, and with continuous feedings at least once a shift. And many hospitals have a policy that that's done more often, but at least once a shift for that. So what is the incidence of tubes being misplaced? In this study by Sorokin and Gottlieb, they documented 1.3 to 2.4% of NG tubes located outside the GI tract in the adult population. These two by Ellett were neonatal and pediatric populations and included dislodged tubes or ones that were not placed correctly. And in the first paper in 98, they had 21%, and in 99 up to 44% that were not placed correctly. So this is a significant issue that we need to know that tube is actually in the correct placement. Feedings into the esophagus can increase respiratory distress, apnea, and potentially lead to aspiration. If the tube is curled in the stomach, then it's difficult to get residual when residual may actually be there. And if we're using residual for placement check, then that's not possible to add to that confirmation. And if the tube is placed transpyloric, green residuals may lead to decreasing or stopping feedings, when actually it's because that's where the bile is in the GI tract, and that's supposed to be there. And if it's placed for decompression, it's not going to decompress the stomach if it's not in the stomach. So some methods of confirming placement. First of all, an accurate measurement when it's placed is important. Some recommend marking the tube at the point of entry. I've seen in my own clinical practice that people sometimes put a piece of tape around the tube at the point where it should be at the lip line or at the tip of the nair. The problem with that is that sometimes the tubes can slide through that tape when there's a lot of mucus at the area, so that may not be 100% accurate either. Auscultation actually is no longer recommended because if the tube is up in the esophagus, oftentimes you can hear the air entry into the stomach. If the tube is down past the pyloric sphincter, you can still hear the air. And even if the tube is in the trachea, in some cases, especially in smaller infants, that air transmission is present. So there have been recommendations in the recent past that in neonates we combine the auscultation method with aspiration of fluid in order to confirm placement. But now we're kind of moving away from that auscultation based on more recent recommendations. And aspirating the fluid is oftentimes an important part of determining if the baby is tolerating the feeding or not, although there is controversy about whether a residual really is cause for concern, but that's a different subject. But we know that sometimes we don't get an aspirate, whether it's that the tube is curled or there just isn't enough residual in the stomach that we can get an aspirate through the tube. So just because we don't get an aspirate doesn't necessarily mean that it's not in the stomach. So that's not real reliable either. And then there are a couple of papers that talk about the color of the gastric aspirate because you could potentially get an aspirate even if it was in the trachea. And the color actually is no different if you're withdrawing from the stomach or the lungs. It may be very difficult to tell the difference. Of course, if you're getting a lot of milk from the stomach, that would be pretty easy to tell, but it could be just white, clear, tan, and really no visible difference between the two aspirates. So that brings us to pH testing, which has become more popular. This is actually the standard in the adult population, and the pH of less than 4 is thought to be predictive of placement in the stomach, but there are studies that report a range from 4 to 5.9 may correlate with gastric placement of the tube. And there was one study that showed as high as 8 in pediatric patients would be in the stomach. So, and this, again, depends on our ability to get a gastric aspirate in order to test for pH. So there is quite a range of pH, and also you have to have the gastric aspirate in order to test that. So ultrasound is something that is sometimes used in the adult population. There's actually a Cochrane review looking at ultrasound to confirm NG tube placement in adults, but they found that it is not as accurate as X-ray, so rather recommended it when X-ray was not available, such as in the emergency room or something like that. In the neonatal population, we've used ultrasound for PIC placement, and there's one paper that I have listed here by Dennington in 2012 where they reported on the use of ultrasound as confirmation of ET tube position and found 90% accuracy and ready availability of doing the ultrasound. They just had like a bedside ultrasound machine that could be used quickly to confirm ET tube placement. So this may be something that we see coming in the future that would be quick and easy for confirming NG tube placement in neonates. The X-ray confirmation or radiologic confirmation is, of course, the gold standard. The problem with that in neonates is if we're going to confirm feeding tube placement before every feeding, that means the baby's getting about 12 X-rays a day, and that's not going to work. So we have concerns about the radiation exposure, having X-ray come every time we need to confirm placement. I know there are places that use the long-term feeding tubes and will use X-ray to confirm placement of the long-term feeding tube, but again, that doesn't give you feeding confirmation of appropriate placement, and we know that babies can pull those tubes out, or we can in our movement of the baby, so that doesn't give you an ongoing confirmation. And then finally, just there has been shown to be variation in interpretation of where the tip of the feeding tube is, even on the X-ray, so it may not be 100% accurate even with X-ray. So what can we take from all of this as far as getting accurate placement of the feeding tube? We want to immediately discontinue the auscultation method as a sole method to confirm feeding tube placement. Discontinue the nose to ear to xiphoid as a predictor of how far we should put the tube in. Consider use of pH testing, and there are some algorithms out there that might be helpful if you're looking to change your clinical practice around this, because again, the pH testing is not always confirmatory or possible if you don't have gastric aspirate, but in the paper by Clifford, which is in the Journal of Perinatal and Neonatal Nursing, there's a very nice algorithm that looks at when X-rays are recommended and kind of helps the practitioner figure that out. So for high-risk situations, difficult placement, babies who are neurologically impaired, have no gag reflex, if there's a change in the clinical status for a patient who already has an indwelling feeding tube, you can't get gastric aspirate, or the pH is greater than 5 and the color is clear, tan, off-white, pale yellow, or green, an X-ray, a confirmation X-ray would be done according to that algorithm. So let's move on to risks of gastric tubes. We've talked about misplacement, and we'll talk about infection here in the next few slides, and then tubing misconnection, and finally perforation. So what is the risk of infection from nasal or orogastric tube? Probably higher than one would think based on some recent data, well, actually data that's been around for a while, but I was a part of the California Collaborative to Decrease. It started out as a CLABSI project, and then it went on for about 8 years, and so we got to a point where CLABSI rates were very low and didn't seem like we could really make any additional improvements on CLABSI rates. And so we began to look at infections overall because we realized that the use of antibiotics had impact on the risk of infections in a negative manner. And so what was the reason that antibiotics were being given? And so we began to look at all infections, and we asked the hospitals that were involved in this project to do a root cause analysis on any nosocomial infection that was diagnosed. And what we found after CLABSI, that the second most common source of infection was the GI tract, necrotizing enterocolitis or feeding intolerance, where there was some conclusion by the practitioners involved in the care that there was bacterial translocation, which led to bloodstream infection. So because this was the second more common, we began to look into this further and really kind of try to pay attention to feeding tubes and what was going on with that. So I'll share with you some of the literature that's out there about that. First of all, we know that there's a bacterial biofilm that forms in the feeding tubes, and the biofilm becomes even more problematic because it encapsulates the bacteria so that it's environmentally resistant and may be resistant to antibiotics as well because of that. And this is reported as a risk factor in post-surgical infections in adult patients, the presence of a feeding tube. So as far as the neonatal studies that have looked at the contamination and bacterial growth in the tubes, these are 3 of the early studies that looked at this and the growth over time. So we'll look at these in a little more detail in the next few slides. But this is from Harrell's paper published in 2009 and an enlargement of the biofilm that they found inside the feeding tube. And you think about now we're giving a baby a feeding through that tube, and this gunk could potentially go into the baby. It's not really very appetizing at the least, and could be deadly. So this more recent paper looked at E. sakazaki, and you may remember that as being the organism that was linked with contamination of powdered infant formulas, and is the reason that we don't use powdered infant formulas in the neonatal unit unless there's nothing else available, and that is now called Chronobacter sakazaki. And they wanted to look at gram-negative bacteria because it's more likely to create a biofilm. And this group looked at it not only in the feeding tube but also on stainless steel because the material or the equipment used to prepare the feeding were stainless steel, and so they were looking at how could those be cleaned properly so that that bacterial biofilm didn't form or was eradicated. They found the biofilm formation was temperature and nutrient dependent, so they used the various augurs or broths to grow this, lettuce broth and a soy broth, as well as an infant formula broth. And it only grew in the infant formula broth at the warmer temperature of 25 degrees centigrade, didn't grow even in that broth at the 12 degrees centigrade. So it's got the perfect environment in a feeding tube to grow because it's got the infant formula broth, it's got the right nutrition, and it's in the baby at a warm temperature. So certainly that biofilm can form there. So this was Mihal's early study from 2002 where they looked at the complications related to this bacterial contamination. They had 50 infants. Tubes were cultured after 7 days of indwelling gravity feeds. 71 out of 125 of the tubes were heavily contaminated with 3 different types of bacteria, and they found that feeding intolerance occurred in 24 out of 32 babies who had contaminated feeding tubes versus none out of the 44 who did not have contaminated feeding tubes. So, and I know that the numbers don't quite match, but they took several feeding tubes from each infant and then looked at when the feeding intolerance occurred related to when that tube was contaminated or not contaminated. And then Harrell's study looked at, they had 129 feeding tubes from 2 different NICUs. 44% of the babies were receiving breast milk, some with fortifier, some without, and the rest were receiving formula. 76% were colonized with species that are associated with outbreaks in the NICU, and there was no difference in isolation rates by the type of feeding, but biofilm was less common in those babies who were fed breast milk. And the colonization was related to the duration of insertion, and their tubes were only in for 48 hours before they found colonization. They also found higher colony counts related to postnatal age. So the older the baby was, the higher the colony count in the feeding tube, which kind of led to the thought that are these bacteria in the feeding tube coming from outside the baby, the environment, or inside the baby in a retrograde type growth up the feeding tube, and that's been shown in the adult population, certainly. So this study really looked at a subpopulation in Harrell's study where they looked at the E. coli that was found in that first study, and they looked at E. coli because it has a high likelihood of causing meningitis, has a high mortality rate, and higher neurologic sequelae rate. So, and we know that E. coli is a common organism found in sepsis in the neonatal unit. But they concluded after looking at this and typing it that the E. coli was likely from environmental sources and not from the infant. And some of those strains were found to be antibiotic resistant, specifically to penicillin and ampicillin. So what about colonization of the GI tract? We believe that in most cases the GI tract is sterile at birth, but quickly colonized with mother's normal flora, especially if they're delivered vaginally. It takes a little bit longer for that colonization to happen in normal-term babies that are born via cesarean section. And then if they're in the NICU, that we know that colonization of the GI tract is different. And the colonization in the preterm infant is different because of antibiotics that they get, if they're NPO for any length of time, and then presence of feeding tubes. And even in a term infant, it takes about 2 years for them to gain the adult microflora in the GI tract. And that's important because the more diversity there is in the organisms that are in the GI tract, the less likely you are to have overgrowth of something that then could cause bacterial translocation and bloodstream infection. So we see infants that have less than 20 different bacterial strains. Adults have over 400. And preterm infants are slower to gain the bifidobacteria, which of course is in breast milk, but even preterm infants who are exclusively human milk fed usually get smaller amounts and over a longer period of time, so it takes longer for them to gain adequate colonization of bifidobacteria that helps control the growth of more pathogenic organisms. So this study looked at the colonization of the GI tract and growth in the enteral feeding system. So the diets in the babies that were included were mother's own milk, donor milk, and preterm formula. And they took cultures from the connector between the extension tube and the feeding tube, and also cultured infant stools for comparison. And they found a thick bacterial biofilm formed at the connector within 24 hours. And bacteria were shared from the enteral tube to the infant feces, and you can see several of them listed there that some you would expect and some maybe not so much. But so they found the same organisms in many cases. They didn't find any difference due to infant diet, so whether they were getting mother's own milk, donor milk, or preterm formula. And 15 of the cases showed that the bacteria was in the feeding tube days before it was in the stool, and 16 cases showed the reverse. And these samples were taken weekly starting at day 0, so they followed what happened on a weekly basis. So certainly there's sharing of bacteria both directions into the feeding tube. So I wanted to talk just a little bit about the effect of antibiotic use. These are 3 papers that have linked antibiotic exposure to necrotizing enterocolitis and late-onset sepsis and even mortality. The first study by Alexander in Journal Pediatrics found more than 10 days of antibiotic exposure resulted in a more than 3-fold increase in the incidence of necrotizing enterocolitis. Every additional day of antibiotic treatment was associated with about a 20% increase in NAC. And then prolonged initial empiric antibiotic therapy found 2-fold higher incidence of late-onset sepsis, NEC, or death, and a 3-fold higher incidence of late-onset sepsis alone. And in the last paper there by Cotton found about a 4% increase in the odds of necrotizing enterocolitis or death with each additional day of initial antibiotic treatment, 7% risk of NEC alone, and a 16% increase in mortality. So certainly that bacteria that colonizes is going to be changed if the baby is being treated with antibiotics, potentially leading to more resistant organisms that invade the infant and lead to poor outcome. So how can we manage that bacterial load? First of all, the initiation and maintenance of human milk feeds that help provide the more normal colonization and bifidobacteria that's important in the GI tract. Limit and de-escalate antibiotic effects on the gut flora, so our antibiotic stewardship programs. Some people are using probiotics in the neonatal population. The literature on that is very supportive of probiotic use. The problem is getting the right probiotics mixed to the right content so that we know what we're actually giving to the baby. And then limit the potential for introduction of pathogenic bacteria through ideal tube management. And I'll just move on to the next slide to talk a little bit more about that. There's not a lot of research to support this. I'm sorry, I just had an interruption, but there's not a lot of research available to support the practices, but most just make sense. The management of the feeding tube to maintain cleanliness. So when we talk about our CLABSI programs, we want a closed system so that we're not introducing bacteria into the baby, and it makes sense that the same should happen with our feeding tubes, that we want a closed system that is as clean as possible, even though we don't think of the GI tract as being sterile. Certainly it's not sterile, but we don't want to introduce any pathogenic bacteria in that process either. So using gloves when inserting the feeding tube, securing the feeding tube adequately so that it's not moving in and out, verifying proper placement, and then perhaps flushing of the gastric tube to get rid of that residual milk that might be in the tube that would provide a ideal growth environment for the bacteria. And then as far as feeding tube dwell time, there are no recommendations other than manufacturers' recommendations as far as how long the tube should be left in. This was just an informal survey that I did back in 2013, where at that point in time, the majority of the people, and this is a small sample, but majority of the people were changing the tubes every 7 days, and you see some were every 3 days, and some were every 24 hours, and there was one that didn't leave the tubes indwelling for feed, so it was changed with every feeding. So, you know, other than manufacturer's recommendation, we don't have any real good evidence, except that we know that the longer the tube is in, the more the bacterial biofilm forms. And the studies really haven't looked at the type of tube that's used. So whether it's a PVC, polyurethane, or silicone, does that change the biofilm that might form in that tube? So this kind of leaves out there in question, what about long-term feeding tubes, and is the bacterial biofilm formed differently in those feeding tubes? And I would think at the very least we want to be very careful about the long-term feeding tubes in creating that closed system and how we manage those so that we're not introducing bacteria. So I'll move on in the last few minutes that I have here to talk a little bit about the other complications, tubing misconnection and perforation. So feeding tubing misconnection was first reported in the literature in 1972, and this was in a neonate. So this is something that's happened and is reported for many, many years. You can find reports online at various sites, the FDA, the Institute of Safe Medication Practices, USP, and ECRI. Finally, Joint Commission issued a sentinel event alert in 2006 about tubing misconnections. And most of these reports are in the neonatal population. Why is that such a high risk in our population? Well, first of all, most of our babies have a feeding tube. And secondly, most of them also have an IV. So those two switches can certainly happen in our population. And you can see from this picture I put in here, there's a PICC line extension and a feeding tube laying there side by side. And, you might say, well, don't leave them side by side. And, of course, that makes sense, although it happens. And these, someone might say, well, they're different colors. I can tell the difference. But nevertheless, we're all humans, and it's the human factor that becomes difficult. And, the cases where these are misconnected are often there's a combination of things that leads to that happening. So being in a hurry, being tired, it's dim at the bedside, and we try to keep the lights down to not disturb the babies, and so it may not be as much of a notice, or maybe one person has a certain method that they use to determine one tube from the other and kind of keep them separated, such as the IV tubing going to the head of the bed or the foot of the bed, and the feeding tube to the head of the bed, which has been a common practice. And then modifying tubing and connectors. And some of the cases that you see online, you wonder how that connection ever could have been made. But if it's possible to put it in there, somebody can make that happen. But certainly with the feeding tube and the IV tubing, it's much easier to do that with some of the equipment that we currently use. And in the past, we've used the same tubing for both the IV and the feeding. I think people are getting away from that now, but that certainly has happened and still happens in some places. And tubes and catheters used for unintended purposes. Some of you probably remember when we used to use feeding tubes for urinary catheters because we didn't have anything small enough. So that happens probably more in the neonatal unit than other places. Multiple ports with similar access, and many disconnections and reconnections over a period of time. So what are the consequences of tubing misconnections? This is one report that I found. A premature male infant who was accidentally given 10 ml of express breast milk IV over a 3.5-hour period. Survived this event with supportive care. This boy was attending regular school, no obvious neurologic or learning difficulty at 6 years of age. So it was a good outcome for this baby. But this group did an email query on the NICU NAT discussion group and were informed of 8 similar events that proved fatal in 3 infants. So certainly we know that this can have a very bad outcome, and probably don't know the extent of this because not all of them get reported to the FDA or ISMP or in the literature. So it's probably underreported. So these are some recommendations that the Joint Commission made to trace the tubing to the point of origin before any connections or reconnections are made, recheck connections and trace all patient tubes and catheters to their source when you transfer to a new setting, labeling tubes and administration sets clearly, but the only real way is to change the system and create tubing that's impossible to misconnect, syringes that are impossible to misconnect, and feeding tubes used only for feeding. So to that end, this group called GEDSA, which is a group of medical device manufacturers, came together and wanted to create a standard for how the tubing connections were created, because prior to this, as many of you may know, there were feeding tubes with quote-unquote enteral-only connection, but some of them were proprietary, so unless you got all of your supplies, your syringes, tubing, and feeding tube from the same manufacturer, they didn't connect together. And that led to occasionally back orders or low stock, and you needed to order from somebody else, and it didn't fit the system that you had. So they created this NFIT connector, which some of you may have heard of. It is available from most manufacturers, although the other enteral-only connections are still available as well. And they've basically flipped the connector so that the syringe has a female connector and the tubing has a male connector. But this has created some issues for the NICU because of our oral small volume medication administration and this little moat, if you want to call it that, around this connection, that the medication can pool in there and the baby doesn't get all of the medication, and especially with such small volumes, that could account for half of the medication. So still some issues to be worked out there, but definitely progress being made. And finally, perforations related to the tube placement. So this incidence has been reported at 1 in 124 in preterm infants, or 1 in 25 in infants under 750 grams. And this was a retrospective review. Sometimes linked with PVC tubes, and remember the PVC tubes are the stiffer tubes, so you would expect it would be more likely to cause a perforation. And this X-ray here is a case that was reported in the article by Filippi out of Italy, where the tube is in the lung, has perforated the esophagus into the trachea and is infusing milk into the lung that you can see there on the X-ray. So others report the incidence as rare. Again, we probably don't know the true incidence. I've actually known this to happen in at least 3 cases in my 30-year career. But none of those were reported in the literature, certainly. So there reports happen in term babies as well as preterm. You might think that, well, a preterm infant has tissue that is much more friable, so it would be easier to perforate that, but it's been reported in term infants as well. Most of the papers don't mention the specific materials of the tube, so is silicone less likely to do that than polyurethane or PVC? Most reports are outside the U.S. where they might be using a PVC tube, but several are in the U.S., so certainly this can happen with materials that we currently use in the NICU. So the recommendation from this is really to gently pass the tube, soft material of the tube that is more less likely to cause damage or perforation, and to lubricate the tube before passing it. So thank you for your attention. I just like this little quote. There's a tiny person on that spec that needs my help from Horton Hears a Who, that our tiny patients are babies that depend on our expertise and constant questioning of our current practices to improve their care. So we don't really have time for questions today, but here's my contact information. So if you have questions or comments and would like to email me, certainly feel free to do that.